Because a lot of times when I talk about trachs, you kind of mentioned, Vince was kind of talking about trauma, right? So I said Vince, I didn't mean Vince. I know, it's been a long day. Manny mentioned about like trauma. So, you know, you kind of think somebody getting a gunshot or a car accident or something like that. Okay, yeah, I can see that. And then you think about like somebody being weak, you know, maybe Guillain-Barré or something like that. Okay, yeah, I can see that. But how long should we have somebody intubated before we think about traching them? You guys think?
You should go as long as possible.
Go as long as possible?
No.
48.
48 hours?
48 hours in space and then trach them?
You know? Trail's gone cold, go ahead and trach them.
I thought I saw
2 months?
I have no idea.
How many days? 2 to 4 days? That's pretty quick. That's a weekend. You know?
That's like, so wouldn't you really just look and see how their body's reacting or what's happening since traching is so common?
So I mean, why would you want to trach somebody instead of keeping them intubated?
Because it's a long-term solution.
Well, what are the problems with intubation?
Putting continuous
Aspiration?
pressure on the trachea with the balloon inflated.
Okay, so when you have that pilot balloon inflated to hold it in place, you're keeping that trachea pushed open, and so you could aspirate. Yeah, you can aspirate with a trach too. But then also, what happens if you put pressure on something for a while? Ischemic and necrotic, right? So you can have tracheal ischemia and necrosis that can happen. What about those vocal cords? What do you think about those things? You kind of damaged and you can't talk and things like that, right? And then the other side, like I kind of mentioned, like if somebody's intubated, you know, they're having to move all of that extra air, not only from here up to here, but then through the tube and then out into the tubing and everything. So that's a lot of dead space in the tube, right? You guys ever like, in a pool, you're playing with a pool noodle or something like that, and you blow in the pool noodle to blow the water out, you know?
Yep.
Yeah, a little bit. Versus like if you had water in your mouth and you just spit it, right? It'd be a lot easier to just spit it out of your mouth, shorter distance, versus using the pool noodle. We're trying to blow the water through it. Some of you are like, I have no idea what he's talking about. But I'm trying to get across the point, like, if you're trying to clear your secretions and things like that, you got to move it a whole lot more of a distance. It's going to take more effort. You got to have the strength to do that. You see what I mean?
Yeah.
So as far as keeping people intubated, no more than a week really. After a week, we should really be looking to trach them. I know some of y'all are like, that's pretty fast. But there's a lot of damage that comes from being intubated for a while. Actually, I did a project 13 years ago that talked about evidence-based practice and not having patients intubated for more than like 10 days. And there was a whole lot of evidence out there to support it. And now you still go to the ICU and people are intubated for like a month, you know, it's still going on 13 years later. And when I was doing the project, I was like, man, there's all this evidence for like the last decade saying they trach them quicker, you know, they just do better, but yeah, it's slow to go, you know. But anyway, so we're gonna talk about trachs today. We're gonna do some care, some suctioning on them, okay? Now when I talk about care, you know, you get a whole lot of secretions right here, yeah? And they're gonna dip down and kind of get all around here, and what's gonna happen to that skin? It's gonna break down and get excoriated and break down, right? So we don't necessarily want that. We wanna keep it nice and clean, so we're gonna change the gauze that goes underneath here, the little 6-ply gauze, and then the strings that go around. A lot of times you'll see Velcro now, right? And so we wanna change that out pretty regularly so that it's not staying wet and moist, right? Think about soldiers and trench foot, right? Like killed hundreds of thousands of guys, probably in the millions, and it was all about their feet being wet, right? You know, being wet and moist all the time is not a good thing. So the care part is not a big deal. Today we're gonna go over the care. I mean, it is a big deal. You're gonna do the care, you're gonna do a peer check-off, you're going to turn in the peer check-off sheet. The suction piece, we're going to actually take a catheter, go into the airway, suction out secretions. Okay, now, we talked about NG tubes, we'll put tubes down to feed people, right? Is that sterile or non-sterile? Okay, now I'm talking about taking a suction catheter going into someone's airway. Sterile or not sterile?
Sterile.
Okay, very sterile, right? Because, why do you have nose hairs?
Get dirt out.
To catch stuff, right? And now we've taken out all of this airway, you know, this oropharynx, nasopharynx, all this stuff that warms and humidifies and catches nastiness, right? We take that out of the loop, we have a straight direct line almost right into the, you know, lungs, okay? Getting infections here is incredibly easy, so you have to be sterile here. So we are gonna do that skill today, and then we're gonna do a faculty checkoff on that skill. You have to show us that you can do it sterilely, okay? All right.
Will the skill checkoff be like the combination of the two?
Nope.
Okay.
No, not the care piece. So we're gonna ignore, we're gonna practice the care piece so that you're confident. But the care is changing out gauze, changing out ties. Once you've done it a couple times, you'll be okay. And again, there's not a sterile component to it. I have confidence that after you've practiced it and demonstrated it to your peers 3 times, that you will be able to do that in a clinical setting under supervision, okay? Now, the suctioning piece is where I want you to really pay attention. So there's a couple of pieces here. When we suction, we use a certain amount of suction on the canister. How much suction do we use? 120 centimeters of water, millimeters of mercury. What is that? Millimeters of mercury. Good. When we talk about chest tubes, it'll be centimeters of water, and I want you to understand the difference, but we'll get back around to that. But 80 to 120, and when you give somebody a yonker to kind of suck out their mouth, what do you normally set the suction up to? What do nurses, what have y'all seen in practicing clinic?
I don't see anything.
Have you seen anybody with a yonker? We don't know what a yonker is? Okay. Here's a yonker right here. They use it at a dentist, kinda, yeah. Yonker suction cup. Alright. So, it's like, they put their finger on, sucks it out of the mouth at the dentist's office. Okay, we got a patient, they got a